Wilms tumor, nephroblastoma. Wilms tumor, nephroblastoma, is the most common malignant kidney tumor in children. It arises from primitive embryonic renal tissue and typically affects children younger than 5 years. Accounts for approximately 90% of pediatric renal tumors, usually unilateral, but can be bilateral in 5 to 10% of cases. Epidemiology, peak age, 2 to 5 years. Rare after age 10 years. Slight female predominance. Incidence, about 1 in 10,000 children. Etiology and genetics. Wilms tumor develops from abnormal persistence of embryonic kidney tissue, nephrogenic rests. Important genetic associations. WT1 gene, located on chromosome 11p13. Tumor suppressor gene. Mutation predisposes to Wilms tumor. WT2 region, located on chromosome 11p15. Associated with overgrowth syndromes. Syndromes associated with Wilms tumor. WAGR syndrome. Wilms tumor. Aniridia. Genitourinary abnormalities. Retardation, intellectual disability, Dennis-Drash syndrome. Gonadal dysgenesis. Nephropathy. Wilms tumor. Beckwith-Wiedemann syndrome. Macroglossia. Organomegaly. Hemihypertrophy. Increased risk of Wilms tumor. Pathology. Gross appearance. Large, solitary, well-circumscribed renal mass. Soft, tan-gray appearance. Areas of hemorrhage and necrosis may be present. Histology, classic triphasic pattern, 3 components, blastomol cells, small blue undifferentiated cells. Epithelial component, primitive tubules and glomeruli. Stromal component, fibrous tissue, muscle, cartilage, or bone. Anaplasia, large hyperchromatic nuclei, abnormal mitosis, indicates unfavorable histology. Clinical presentation. Most common finding, painless abdominal mass. Other symptoms, abdominal pain, fever, hematuria, hypertension, anorexia, weight loss, nausea and vomiting. Physical examination, smooth, firm flank mass. Usually does not cross the midline. Diagnosis, laboratory studies, CBC, renal function tests, liver function tests, urinalysis, imaging, ultrasound, initial investigation, confirms renal origin, CT scan, determines tumor extent, evaluates contralateral kidney, MRI, useful for vascular involvement, assesses inferior vena cava extension, chest imaging, chest CT to detect lung metastasis. Differential diagnosis, neuroblastoma, hydronephrosis, multicystic dysplastic kidney, renal cell carcinoma, rare in children, mesoblastic nephroma. Staging, Stage 1, limited to kidney, completely excised. Stage 2, extends beyond kidney, completely resected. Stage 3, residual non-hematogenous tumor in abdomen. Stage 4, hematogenous metastasis, lung, liver, bone, brain. Stage 5, bilateral renal involvement. Treatment, management depends on stage and histology. Surgery, radical nephrectomy is the main treatment. Bilateral disease may require nephron-sparing surgery. Chemotherapy, common drugs, vincristine, dactinomycin, actinomycin D, doxorubicin. Radiotherapy, used for stage 3 and IV disease. Unfavorable histology, residual tumor. Prognosis, Wilms tumor has an excellent prognosis. Favorable histology, survival greater than 90%. Unfavorable histology, anaplastic, lower survival rates. More resistant to therapy. Poor prognostic factors, diffuse anaplasia, advanced stage, tumor rupture, loss of heterozygosity at chromosomes 1p and 16q. Key exam points. Most common malignant renal tumor of childhood. Peak age, 2 to 5 years. Painless abdominal mass is the classic presentation. Associated with WAGR, Dennis-Drash, and Beckwith-Wiedemann syndromes. WT1 mutation on chromosome 11p13. Triphasic histology, blastomol, epithelial, stromal. Lung is the most common site of metastasis. Anaplasia equals unfavorable prognosis. Treatment, surgery plus chemotherapy plus or minus radiotherapy. Overall survival exceeds 90% in favorable histology cases. Mnemonic. Wilms, W. WT1 mutation. I. Infant, young child, 2 to 5 years. L. Large painless abdominal lump. M. Metastasis mainly to lungs. S. Syndromic associations, WAGR, Dennis-Drash, Beckwith-Wiedemann. Thank you.